Okay, welcome everyone to the second session of the 2020-2021 CHI Patient Engagement Lunchtime Learning Series. In this session, our patient engagement lead, Carolyn, Shimmin, and myself, Trish Roche, knowledge broker in patient engagement and knowledge translation, will share our recently published work on the Valuing All Voices framework for meaningful, safe, and inclusive patient engagement in health research. We're also joined by our co-presenter and patient co-researcher on the project, Serena Hickes. For this session, attendees are automatically muted. If you would like to make a comment, ask a question, please use the chat box. We have closed captioning available, and you can turn that on using the subtitles button at the bottom of your screen. This session is being recorded and will be available on CHI's YouTube channel with captions. The series is accredited as a Section 1 group learning activity by the Royal College of Physicians and Surgeons of Canada and is an eligible professional development activity for credit from the College of Pharmacists of Manitoba, as well as the College of Registered Nurses of Manitoba. As an accredited program, we are required to disclose any potential conflicts of interest. Both myself and Carolyn are employees of the Center for Healthcare Innovation, and we have no other additional conflicts to disclose. We would like to start off by acknowledging that here in Winnipeg, we are on Treaty 1 land, home of the Anishinaabe, Cree, Oji Cree, Dakota, and Dene peoples, and homeland of the Métis Nation. We also acknowledge that Manitoba includes lands that are the original homes of the Inuit. In coming together today, we respect the treaties that were made on these territories. We acknowledge the harms and mistakes of the past. We recognize the ongoing present-day colonial violence that is faced by Indigenous peoples within healthcare, education, justice, child welfare, and government systems, and we dedicate ourselves to moving forward in partnership in a spirit of reconciliation and collaboration. In talking about patient and public engagement in health research, it is in fact Indigenous research methodologies that are at the forefront, and Indigenous scholars, researchers, and communities that we should be looking to for guidance. And I'll let Serena share some of her experiences with the project and how that went for her.
Oh, sorry. I got muted and then I couldn't unmute. So as patient engagement, a lot of people view that as, yes, we are patients. We also work very hard to engage other patients to help research projects in a very safe way, a very safe space, trauma-free as much as possible. I mean, when you're talking about your medical or your experience as a patient, trauma can happen, and you've got to make sure, and Carolyn's really going to touch on this, is how that happens, that it's such a safe space for patients to be able to share their stories. And even my glasses are distracting me. So that's something that she's amazing at touching on. But as a patient and someone that has worked in the research community for many years now, it's different when you're not only the patient, you're working in patient engagement and you're looking for fellow patients to talk about specific thoughts and ideas of what the project is about. This can be difficult because some patients, and definitely for me, I found that I'm an Inuit woman, so my trust at the very beginning of my career in research was very, it was a really scary thing to trust because I also have a son with chronic health conditions. We'd get into a hospital and it was like they hit the mother load. You know, not only were we Inuit, we were in the South, so we were accessible, and there was chronic health conditions. And it was like that trifecta of, great, let's just attack on them. And that was made it very discouraging, you know, and I learned really quick that you've got to be your own advocate. And if you can't be your own advocate, find someone who has a voice that can be your advocate. And that is even with, even when you're working within, working on this particular project, my advocates were my cohorts. Like these women we always had each other's backs. We always had each other's thought process and the safety of that, of being able to say something. And even if you knew it was kind of going to hurt someone's feelings, it was a safe place to talk about it. There was, as an Inuit woman, I'm a storyteller. So that's a natural given for my culture. And I thought about writing the story that went along with this. And then I was really nervous because I thought, will that story be taken as something that gets published, but then a researcher that maybe doesn't have the reputation that all of these people have that I'm working with, and take that as, we consulted an Inuit expert. I was very nervous about that. My colleagues listened to me very carefully on that, really understood where I was coming from. And you've got to listen. Make sure you're listening. Make sure your heart and your ears are open. And I say your heart because this is your life story. It is a big part of your life story. And I've got a dog barking. Sorry. So with all of these things being said, when you've got the trust, make sure when you're building onto that in your own research project, you stay with people that are trusted. Stay within that. And if there are people that need a little bit of education on why patient engagement is so important, it's okay to have that conversation. It's a hard conversation, but it's okay. It's really, it's much better for us as patients and patient engagement, for people to have these discussions instead of just, well, we'll just bypass it. We'll hope it gets better. Talk about it. We're in a field where people sometimes can be afraid to have these hard conversations, but they've got to be had. Again, these are things that Carolyn's going to touch on, and I'm so happy because then I don't have to. But it's so nice because we come from such different backgrounds, and all of us were able to sit down and have an open dialogue. What a treasure that is. Some of my chronic health conditions, some of my son's chronic health conditions came into, because it does come into your work. And these are very sensitive things. Remember to make sure, I can never say it enough, make sure that there's a safe space for all of your patients you're trying to engage. It was really cute because I definitely found that the newcomers, they were so excited, and yes, there was some distrust, but it was like, hey, come have tea with us. Let's cook samosas. I never ate so many samosas. And I happily did, by the way. It was worth every 5 pounds I gained. But, get attached to that excitement, and it's okay. Even though I've had some bad experiences, I get to share that excitement that the patients that came onto this project, that was a joy for me, because that wasn't always my experience in research as an Inuit woman, because we generally were kind of disposable as Indigenous people in this country. So it was exciting to see these excited faces. So just don't forget to engage. Please engage. Make sure you've got a safe space. If a hospital is a trigger for people, do not hold your meetings at hospitals. Find a community center, whatever it may be. But make sure it's on their territory, not yours. Their home turf, not yours. Because that's where they're going to be the most comfortable, and they're going to share, honestly, a lot more because they've seen you go the extra mile. And that's what happened here. People were happy to go that extra mile because we did. So anyway, well, good luck. And this was an amazing project. If anyone ever gets to work with any of these amazing researchers, I say please do, because you'll get nothing but great results and great communication. So it was quite a ride, but it was a really good one.
Awesome. Thanks so much for sharing, Serena,
Yeah.
and all your kind words. You're so sweet.
Uh,
And we've missed you. Okay, I'm going to turn it over to Carolyn to talk about some of the foundations of the project.
Thank you so much, Serena. It's been a privilege, I think, working with you, and all of your insight is so amazing. And this is actually, I guess this quote really follows what Serena was talking about just a second ago. And I like to start off with this quote to remind us that as human beings, we're complex. We simultaneously inhabit many different social locations. And when we come together, all of us as individuals bring our own political, cultural, economic, subjective, and experiential knowledge to the table. And what this means is it can be messy at times, and it can be uncomfortable, and it can be complicated. But as researcher Brené Brown says, vulnerability is the birthplace of innovation, creativity, and change. And so for me, I know I always have to continuously remind myself of this when it comes to public involvement, whether it's in health research decision-making or health systems change and decision-making as well. Do you think we can change the slide? Thanks. So it all started out a long time ago. In 2015, the Center for Healthcare Innovation held a stakeholder workshop that included 50 different stakeholders who represented patients, caregivers, researchers, healthcare practitioners, community organizations and decision makers, to really discuss the current state of patient and public engagement in health research. And the start of the day was a World Cafe, and we really talked about barriers and facilitators. And then the second part of the day came around, and that's where all that complicated, uncomfortable conversation started to arise as we talked about how do we move forward. And so there were disagreements, right? Around the terminology that we're using, the identity of patient. There was a lot of insight around that there were missing voices from the table, that not everyone had been included, and that it seemed very top down. And so we kept having these conversations afterwards, thinking, reflecting on people's concerns about the conceptualization and the terminology that didn't resonate with them, that it lacked inclusivity, which is one of the fundamental principles of engagement. And that's when it was realized that it wasn't about the terminologies or the words patient engagement, but rather the concept itself was problematic because it negated the real complexities and context of people's lives. And though we conceptually started to disrupt the identity of researcher by kind of challenging and complicating assumptions and around expertise and knowledge, we continue to kind of essentialize the identity of patient. And so what we realized was when approaches and methodologies are created based upon a definition of patients as a homogeneous group that we simply need to engage more in health research, it denies the reality that individuals' economic, political, subjective, cultural, experiential lives really intersect in intricate and multifarious ways. And it may exclude the involvement of individuals who may not even identify as a patient for a variety of reasons. So this can include people who are unable to access the healthcare system because of geographical barriers, so rural, urban, remote, or systemic barriers, so facing racism, colonialism, sexism, transphobia, classism, ableism within the healthcare system. It also excludes individuals living with mental health or substance use issues who may be hesitant to take up the label of patient because there's so many associated stigmas with this label. It excludes people who refuse to engage or prematurely exit the healthcare system because of really unresponsive or disrespectful care. And then it also can exclude people living with disabilities who feel they've been continuously medicalized by the healthcare system. And we know that we have substantial and robust evidence that points to the existence of a social gradient in health. And this means social and economic conditions and their effects on people's lives determine their risk of illness, the actions they're able to take in order to prevent themselves from becoming ill, and treating illness when it does occur. And the roots of patient engagement originated from the world of HIV and AIDS research, as well as the disability movement, where the phrase "nothing about us without us" was coined. And it grew out of a sense of democratic purpose, where people who were affected by research have a right to have a say in what and how publicly funded research is carried out. But there's been this shift in recent years, where we first went from conceptualizing the involvement of patients in health research, either as a means towards better personal health decision-making, so the idea that the involvement of the public will increase their understanding of health research, which in turn will strengthen some people's ability to make good decisions about their health and their families. And then we further shift it to seeing the ultimate goal of public involvement in health research as enhancing research. So the involvement of patients in health research will improve the quality and the transparency and the relevance and accountability of research. But what happened with this shift in thought was that it suddenly became more of a top-down approach that centers on the primacy of researchers' needs over the needs of community. And in turn, it starts to replicate and kind of reproduce already existing health inequities by privileging certain voices, so mainly white, middle class, well-educated people who have relatively fair access to the healthcare system, can navigate the system with comparative ease, and feel really comfortable in identifying as patients. So we wanted to reframe the central goal of patient and public engagement as a matter of health equity and social justice, much like community participatory research action, only further expanding where participatory frameworks often leave off by addressing the impact of the complex interplay between systems of power and formation of identity of both researchers and patient co-researchers. And so in reframing this goal, we're hoping to expose kind of spaces of potential resistance and renegotiation of power when it comes to these relationships, and move towards truly meaningful and transformative collaboration built on trust and transparency and respect and dignity for all. And if one of the primary principles behind patient engagement in health research is inclusivity, and the key driver is to improve health outcomes of everyone and enhance the healthcare system, then we started to argue that it must incorporate a trauma-informed intersectional analysis in order to ensure that health inequities are addressed and not simply reproduced. Now, a lot of people are like, what is intersectionality? And we've heard a lot about intersectionality lately, whether in pop culture, and it's brought up and discussed way more, and this is really exciting. But here is a little bit of a way I discovered this wonderful little cartoon that people might more relate to explain what is intersectionality. It's a cartoon by Miriam Dobson. So this is Bob, and he is a stripy blue triangle, and he should be proud. But sadly, some people do not like Bob. Bob faces oppression by being a triangle and for having stripes. And luckily there are liberation groups, but they aren't intersectionality. So they look a little bit like this: welcome triangles or welcome stripes. And so these groups don't talk with one another. And in fact, there's a competition kind of between the two of them. And so poor Bob doesn't know where to go. He can't work it out. He's like, am I more stripe? Am I more triangle? And he wishes the triangles and stripes could work together. So oppression of one affects us all. No liberation without equal representation. So intersectionality is the belief that oppressions are interlinked together and they can't be solved alone. So oppressions are not isolated. And he says, intersectionality now. Oh, Bob. So the concept of intersectionality emerged from a number of theoretical groundings, including US Black feminism, Indigenous feminism, Third World feminism, queer, post-structuralist, post-colonial feminism. And the term itself was coined by Kimberly Crenshaw in 1989. And she's an American civil rights advocate and leading scholar of critical race theory. And intersectionality promotes an understanding of human beings as shaped by the interactions of different social locations or categories. So for example, race, ethnicity, indigeneity, gender, class, sexuality, geography, age, ability, immigration status, mental health status, religion, all of these different things. And it's really important to understand when it comes to an intersectional perspective, these categories are considered dynamic, meaning they change over time and they change geographically as well. If we think about gender identity and how we define gender, it's changed over time. It changes depending on your geographical location, so it's historically grounded as well. These are all socially constructed categories, meaning there is no basis other than they're used as in a way that is socially constructed for larger systems of power and oppression. And then they operate on various levels. So they operate on the micro level of the self and how we relate with one another. They operate on larger levels, on the way in which we interact with institutions, and then also at a global level as well. And interactions between these categories occur within larger contexts of connected systems and structures of power, so laws, policies, government, media, public institutions, and through these processes, interdependent forms of privilege and oppression shaped by colonialism, imperialism, racism, homophobia, transphobia, patriarchy, ableism, saneism, all of these different things come into play. And to put it more simply, one of the prominent intersectional theorists, Alina Hankivsky, says inequities are never the result of single distinct factors. Rather, they're the outcome of different social locations, power relations, and experiences. And according to the amazing Audre Lorde, there is no such thing as a single issue struggle because we do not live single issue lives. So what does this have to do with patient and public engagement? People are like, okay, this is a lot to take in. What does this have to do with engagement? Well, a central goal of intersectionality is the social inclusion of voices who are traditionally less heard, including populations often ignored and excluded. And this is achieved by various means, including conceptualizing social categories as interacting with and co-constituting one another to create unique social locations that vary according to time and place. Everybody always laughs because I start doing this. So it's like an oscillating web, if you can see my hands on the screen. And it's not so much about the intersection itself, but it's about what that intersection tells us about power, systems of power. And that's one of the ways that you can kind of think about it. And intersectionality involves a multi-level analysis. So we're looking at the macro, so global and national level institutions and policies, the meso or intermediate, the provincial and regional level institutions, and then the micro levels, so the community levels, grassroots community interactions, and the way in which we even see ourselves. And now we're gonna just add in an extra layer for everyone because it's lots of fun. We also want to look at an often overlooked aspect when we think about patient and public engagement, and that's the role of trauma, which Serena had mentioned earlier on. So recognizing that the experiential knowledge that people bring to the table may be intertwined with experiences of trauma. And we know that this can have a significant impact not only on one's health, but also our responsiveness to interventions as well. It can impact the way we access appropriate healthcare and hence even identify as a patient. So embedded into any engagement practice, we want to think about, we always need to recognize that trauma is a widespread, harmful, and costly public health issue that needs to be addressed. And that it doesn't solely live in the realm of public and patient research partners, right? It also lives within the realm of researchers too, who may have had some experiences of trauma as well, and who may even be attracted to the area of research in which they're working because of their past experiences. So there needs to be that understanding that healthcare systems as well that are intended to provide services and support can be trauma inducing as well. So behavioral health system or invasive procedures within the medical system as well. And we need to understand that traumatic events by their very nature set up a power differential where one entity, whether it's an individual, an event, a system, or force of nature, has power over another. And so when we think about that, we don't want to redo that when we're engaging, right? So we want to think about ways in which we can not replicate feelings of powerlessness or reproduce any of those feelings that were felt in the engagement practice itself. And by acknowledging that the role of trauma and being prepared to address these issues, it makes things a lot safer for people to come forward and share their experiential knowledge. So substance abuse and mental health services administration guidelines is the three kind of components when it comes to being trauma informed is recognizing the widespread impact of trauma, recognizing the signs and symptoms, and actively resisting re-traumatization by creating physical settings and interpersonal processes that support safety. Oops. And why we want to use it, why it's so important to use a trauma-informed approach. Well, it actually is a way to sometimes find a common ground, and it disrupts the process of othering sometimes as well. It exposes the instability of some of those socially constructed categories we talked about before, patient partners, research and practitioners, and it reveals sometimes opportunities to renegotiate power and strengthen that trust in building resiliency. And learning to be critically reflexive is one of the ways in which intersectionality pays attention to power. Reflexivity acknowledges the importance of power at the micro level of the self in our relationships, as well as the macro levels of society. It recognizes that there's multiple truths and a diversity of different perspectives, and enables us as a team, whether researchers and patient partners, that we can recognize there's space for all of these different perspectives to be involved. And it's an important practice for health researchers because, and I think it's central to working ethically in uncertain contexts as well as unpredictable situations. So it's an ongoing dialogue that occurs between patient and public partners around our own social location and power and privilege. And so yes, just understanding subject positions and social categories, that it occurs both on the bodily level as well as the way in which we interact. And that we can start to understand better what types of knowledge and experience have been excluded, and understanding that it's relational and can vary by context. And I think I've already, maybe we can go to the next piece. Sorry. Oh, poor Trish. we're just balancing out the moving around. So how can we be critically reflexive? Here's some questions that you can start off, whether you're a health researcher, whether you're a patient partner, to start thinking about. What are my own personal values, experiences, interests, beliefs, and political commitments in the area of health we will be looking at or researching? How do these personal experiences relate to social locations and processes of oppression in the area of health we will be looking at or researching? How can we become more aware of and take advantage of opportunities where we can challenge each other's ideas and renegotiate power within our project and team? What does resilience look like? This is a really important one as far as strengths-based approach. What does resilience look like, feel like, and sound like to us? And this can help shape your evaluation. What does success look like to us at the end? When we're thinking about our engagement strategy, how do you think we can make sure that everyone's perspectives are included and that we address inequities as well as social issues of social justice? And in what ways do you think we can work together to make sure everyone on the team, as well as any people involved in the project, feel safe? And sometimes we do this exercise where we say, what does physical, emotional, psychological, and cultural safety mean to us, look like to us, and feel like to us? And when we're evaluating, did the project or the research team actively work to dismantle past cultural stereotypes and biases in their work? Did the project team have access to cultural and gender responsive support services in case a researcher or a patient partner required some additional support due to the past experiences of trauma? Yay, we're gonna pass it over to Trish to talk about the wonderful framework.
Great, thank you, Carolyn. So based on these principles and in response to feedback from Manitoba patients, caregivers, families, communities, healthcare practitioners, decision makers, researchers, and other stakeholders around the need for more meaningful and inclusive patient and public engagement in health research, we developed the Valuing All Voices framework. I'll share some info about the development, the research process, and the refined framework published in July of this year in BMC's Research Involvement and Engagement. Here we have the Valuing All Voices team, some of whom joined a little later in the project, like myself and Masood. It includes researchers in knowledge translation, Indigenous health and disability studies, patient engagement and knowledge translation practitioners, including myself and Ogai, and of course, Carolyn, research staff, and our lovely patient co-researcher, Serena Hickes. Through a deliberative discourse, this team worked to develop this draft version of the Valuing All Voices framework. So this draft builds upon the existing patient engagement framework, which was developed by the Strategy for Patient-Oriented Research, or SPORE, which emphasizes inclusiveness, support, mutual respect, and co-building. And building on this, those key concepts Carolyn spoke about in blue provided a foundation for developing these 4 pillars, namely trust, self-awareness, empathy, and relationship building. The team's goal was to work with people whose voices are traditionally less heard in health research through a social justice and health equity lens to develop a more comprehensive framework to guide research teams in engaging in a meaningful, safe, and inclusive way. As mentioned, we had heard about how current practices of engagement continue to exclude people whose voices are traditionally less heard. In Manitoba in particular, this includes people who identify as Inuit, Métis, First Nations, immigrant, refugee, newcomer, and/or having lived experience of mental health conditions. The team was awarded a SPORE patient engagement grant with matching funds from the University of Manitoba's Max Rady College of Medicine to reach out to communities to discuss and refine the draft framework. The first step in the plan was to connect with community organizations to determine the best ways to approach and recruit participants, as well as co-developing methods for discussing the framework and revising it with participants. And usually we save lessons learned for the end, but I'm going to pop it in here because it's relevant. Some of the lessons that we learned from community organizations and Serena included taking the time to build strong, trusting relationships, and that's absolutely necessary for co-development of research. Because we already had established links to community groups who serve people identifying as having lived experience of mental health conditions, immigrants, refugees, and newcomers, and Inuit, we were able to meet with them right away to discuss methods for recruitment and data collection. However, in following the framework for research engagement with First Nations, Métis, and Inuit peoples that was co-developed with the University of Manitoba, we reached out to community organizations serving First Nations and Métis groups, respectively. We found that because we had not taken all that time early on to really develop those strong, trusting relationships and co-develop the research from the very start with these communities, our priorities were not aligned with theirs, and so they chose not to be involved in the project at the time. For the community organizations we did co-develop methods with, we learned about the importance of flexibility. For example, some people may not be comfortable discussing their thoughts about engagement in a group setting, which was our initial plan. And so we provided participants with the option of one-on-one or group discussions. We also learned to look to Serena for guidance, particularly in working with Inuit participants. For example, part of our methods including using numbers to de-identify study participants, giving them a numbered code for data collection to maintain confidentiality. But because of Canada's history of forcing Inuit people to identify themselves by wearing numbered discs, we were led by Serena to use letters or symbols instead in order to avoid re-traumatization. And that's just one example of the many learnings from Serena and community groups. Another key lesson was in communication and follow-up. Though we had always intended to share our work once the project was completed, in hindsight, we should have anticipated more delays and developed some ways to stay connected and provide progress updates, even if nothing had happened. Because some relationships with communities and participants were through individual team members, when those members were away or unavailable, it was difficult to connect with participants. And so we did lose about half to follow up when we wanted to go back months later and validate the refined framework. All that said, by the end of 2017, we had successfully completed 2 group discussions, one co-facilitated by Serena with 2 Inuit participants and 2 First Nations elders who were identified as being close with participants and acting as supports, and another with 6 newcomer participants living in Canada for up to 5 years, and 3 language interpreters out in Brandon, Manitoba. We also held individual interviews with 5 people identifying as having lived experience of a mental health condition and 4 identifying as immigrants or refugees. In each meeting, whether it was a group or individual discussion, before showing participants the proposed framework, we asked them to provide their own definitions of the 4 components: trust, empathy, self-awareness, and relationship building, what they mean, look like, and feel like to them. We then showed them the proposed definitions from that draft framework I showed you at the beginning and asked them to compare these 2 sets of definitions, let us know what should be changed, added, removed, and otherwise. We compiled participants' initial definitions into word association bubbles, grouped into categories that included definitions, feelings, themes, and sometimes what the concept is not. For trust, participants associated it with feelings of comfort, connection, and safety. Many use synonyms to define trust and themes such as 2-way relationships, accountability, and confidentiality. They told us trust is not superficial or fake and means being able to let your guard down. There were myriad definitions for self-awareness, but a common theme that came out was that of reflexivity, focusing on awareness both of your inner and outer self. Empathy was defined by a number of participants as putting yourself in someone else's shoes or moccasins. There was an emphasis from some participants on distinguishing empathy from sympathy or pity. Some also described why empathy is important: to break down othering and us versus them mentality and gain appreciation for others' feelings and perspectives. Relationship building was associated with feelings of warmth and security, and participants emphasized how it was really intertwined with the other 3 components. And so I'll just share one quote, kind of summing up some of the things we heard. Sometimes you can do all the research you want, but if you haven't actually been through what someone else has been through, it's just a different perspective. And I think sometimes as a researcher, you have to take a step back and say, okay, in this specific instance, their perspective is more valuable than mine because they've gone through it. And so attempting to stay as close as possible to participant definitions and suggested changes, the revisions were compiled into this revised framework, which we were able to validate, as I said, with half the original participants as being representative of what they told us. What's shown in red was removed, and even more so, what's shown in green was added by participants. So that's both the text in green and the boxes. And you're not supposed to be able to see all of this. It is a lot. One interesting finding, though, was that some of the recurring ideas from participants are also represented in those underlying principles of trauma-informed approaches and intersectional analysis. This includes the strengths-based approach to research, focusing on resilience, and self-compassion, both for patient and public partners and for researchers themselves. Participants also provided a whole new component dedicated to education and communication, ensuring everyone is on the same page in research relationships and providing training both to patient and public partners about the research process, but also to research teams looking to engage. They also added some actionable items for each component at the bottom there, providing the how-tos for establishing trust, self-awareness, understanding and acceptance, which is the revised title for the empathy component, relationship building, and education and communication. Overall, in particular, self-disclosure, two-way relationships, and sharing time and experiences with each other were seen as being of really high importance for meaningful engagement. And so this framework has been used to inform our ongoing work in patient and public engagement at CHI, both in health research and health systems and services. It also forms the foundation for development of a number of evaluations of research engagement activities. Although it has been revised with a handful of diverse individuals from groups in Manitoba whose voices are often less heard in health research, we do recognize the importance of continuing to engage and further refine the framework with additional voices, including those we were unable to connect with initially. One thing we heard from a lot of participants is that a simple, striking visual should be used to represent the framework as a whole. I think it took 10 to 15 versions for everyone to come to a consensus on, but we finally settled on this cyclical and colorful image of the Valuing All Voices framework and its components. We look forward to hearing your thoughts on this work, any questions you may have. And yeah, if we can open it up to questions, I think we're good on timing for that. So I'll turn it over to Ogai if there's anything in the chat at all.
Thanks so much, Trish and Carolyn. What a thoughtful presentation and timely. So if any individuals have questions, you can raise your hand and or you can post in the chat box.
Oh, I see a question. I'm not muted, okay. So Michelle says, sorry, my question may not be directly related to today's talk. As a caregiver to a patient and also a faculty member at the U of M, I'm wondering if this study group or other CHI research groups have identified the electronic access to test results for the patients as one of the patient engagement objectives.
I think that's a good question. I think it's something, it's definitely always a priority area when we engage people around access to electronic portals, to be able to, I know other provinces are far more ahead, and so it is definitely seen as a priority area. Whenever we do engagement, it comes up quite a bit, and that is definitely a project that I'm sure a lot of people would be very interested in.
I wonder if we went through too quickly.
It's a lot of information to process too.
It is, yeah. I don't see any hands raised.
There is one question for Amani. How do you see the framework being used by new researchers?
Oh, just Serena. Do you want to unmute yourself, Serena?
Yes, thank you. Okay, so how I know for myself as in this, I would love researchers, especially new researchers, have a way to find mentors along the way on patient engagement, because new researchers, I'm hoping, are understanding the importance of SPORE. I mean, I'm hoping I'm speaking from someone who has worked within this system and with researchers, I want to say 12 years. So a lot has changed, but not enough has changed where patients are, and especially the discussion that researchers are having, that it's not over the patient's head. You're talking with the patient, not to them or at them. And it seems simple, but it isn't. And that's something that I've seen from the 12 years, the difference, and we're still not there yet. I've gone to conferences where it's still, you're, as a patient engagement, you're forgotten on, even though your name's on the agenda, you're kind of sidelined a little. But that again has gotten better. But be aware how your patients are being represented, because you are that representative for them in this research land, because it is your it's your space. So remember to make that as an open of a space, and that you're helping your patient navigate through that, because remember, they didn't go to that, get that education to be a researcher. They're coming along for the ride. So remember to have a really good roadmap. And if something gets bumpy, have their back. It's so important. It's so important as a researcher to not forget that all of the information everyone brings to the table is equal. It doesn't matter who you are, because as a researcher, listen, I don't have your experience. I don't have Carolyn's experience. I don't have Trish's experience. I don't have all of those, but I have the experience of being a caregiver of someone who has chronic health conditions, and I'm a full-time caregiver for that child. And he's 27, by the way, but he's still my child. But I also have my own that I've had to navigate the medical world with and the research world with. So don't forget that everyone's conversations are as equal as someone else's. I don't care what letters you have behind your name. Let's try to keep the perspective that we can't do these without each other.
Thank you so much, Serena. Carolyn, did you want to add a few more words before moving to the next questions?
I think I'd just say the framework is definitely geared towards new researchers who are coming into the area, because I think one of the neat things that we discovered was there was a lot of people who started actually talking about how-tos and giving concrete examples of ways in which you can incorporate critical reflexive practice or trauma-informed methods into your research, whether it's addressing issues around strengths-based, issues around understanding your own social location and privilege. I think the framework really, thanks to all the many participants and perspectives, was able to flesh out what these things are. So sometimes we say it on very high levels, like it should be inclusive and it should be this, but we don't get into what that looks like. And I love that the framework actually gets into what that looks like from the perspective of people with lived experience, but it's definitely speaking to researchers around, like, this is what it's going to look like if you want to engage.
Sorry, I just noticed that there was someone who was asking about, was there a reason you chose to develop a new one? It's not even so much a new one, it's just adding to the model. It really isn't trying to reinvent the wheel. But the other thing that I'd like to point out is there were two groups that, you know, had decided that they weren't on the same page as us, they have First Nations groups and the Métis here in Manitoba, they have their own research departments, and it's okay when someone says no, and don't take it personally. Try very hard not to, because like for some people that means, oh, the no, okay, let's try a little harder, let's try a new. Sometimes you're just not going to be at the same page in the book as another group, and that's okay. You know, you can, there may be something that you can collab on at a later date, but you know, just build that rapport. Stay in contact with those groups that, you know, maybe didn't want to work with you on that particular project, but they may want to collab on something later. So don't forget to stay in touch, and just, I'm a big believer of, you know, pick up the phone. You can get so many emails, you just get bogged down. Pick up the phone and see how it's going over at their end.
That's really important. Oh, did Trish?
Carolyn, did you want to add before?
I know Trish unmuted too.
Go ahead, Carolyn.
I was just going to say, with the different models of engagement, so this one is seen as kind of a complement to the SPORE patient engagement guiding framework that was established, I think, at the very beginning of the establishment of the strategy for patient-oriented research. We developed it because there definitely was always the guiding principles included inclusion and diversity, but it didn't delve into some of those issues around addressing incorporating critical reflexive practice, addressing issues of social justice and health equity. And so it was identified by stakeholders that there was this gap kind of in as far as different models. And so this is kind of addressing that area in which there was kind of a dearth as far as different models are concerned. This was kind of seen as something that could complement other frameworks, but that it addressed some very important issues that were identified by stakeholders.
Trish, did you have anything to add before the next question?
It might kind of go to the other question that's there. A lot of what we heard from participants was, you know, maybe not at the same level language of intersectionality and trauma-informed approaches, because a lot of that comes from academic fields, right, in social work and like critical reflexive practice. So a lot of what they said was very easy to understand, very straightforward things like just talk to people, spend time with people, build relationships, build trust, talk to each other, share your experiences as well, be on the same level, that kind of thing. So I really appreciated from the participants how it was just very easy, and they were like, you don't have to overcomplicate it. This is about building trust and building relationships with each other.
Thanks so much, Trish, for pointing that out, because sometimes terminology can really create more confusion, especially with researchers entering this field. So it was the individuals with lived experiences that really made it easier to understand those bigger concepts. But Antoine's question, and maybe Carolyn and Serena and Trish, if you want to add a little bit more to that, is in regards to the education of patient-public partners. Has the education and awareness of researchers, professionals about equity, power, intersectionality also been raised as key areas of action?
Absolutely. I think the whole framework itself is very much speaking to health researchers. And if you look at some of those other components that talk about self-reflexive practice and things like that, and being self-aware, that is very much something that it's definitely suggestions and ways in which health researchers can grow their understanding of social justice and health equity pieces. But yes, it's an interesting thing that education component was added on, and that it would seem more, I guess it was maybe that we were talking a lot about what do researchers need to know, and so there was also that added education section that was also saying, well, it's a two-way, that we both have to learn around that piece. But it is very much advocating, I would believe, for research professionals to continue to train, to continue to build understanding around intersectionality, around white privilege, social justice issues, and to really challenge themselves on a continuous basis, to have uncomfortable dialogue and to continue to grow their understanding of these things.
Thanks, Carolyn. Because truly having to educate ourselves in deeper self-awareness, that's when we move closer to authentic engagement and move away from that tokenistic type of engagement that we don't want for anyone. Serena, did you have anything else to add?
No, honestly, Carolyn and Trish, they always just nail it. So yes, I also would like to say that, you know, without Catherine Sibley's awareness and picking people and just choosing her team and you know, trusting Carolyn to bring me on, and you just trusting her gut on who should be on this team, was really impressive on my side, because not once did I feel like this team was trying to just keep taking from patients. This was it already seemed like a well-oiled machine, and they were still in their learning phase as well, and you couldn't tell from my end. So I was really blown away at how that just showed how open researchers can be with their mind and their hearts on a project, and they, you know, to trust your gut that the people around you have got this, you've got their back, we have their, like, it just was quite remarkable from a patient engagement perspective, and to see that one, patients were trusted, that, you know, I was in awe, really, I was in awe. And so, Catherine, I just want to thank you openly and just say, hey, you know, thank you for trusting your gut on, you know, who to bring into this project. And for researchers, and that's something maybe for new researchers too, trust your gut. It doesn't need to be everything about the numbers and who's here and who's there. If your gut is telling you to back away from something, back away from it. You know, if your gut is telling you, I need to bring this person on, bring that person on. Have that conversation. So I thank you so much, because not all research projects have I been involved with left such a flowery experience. Some left a really bitter taste in my mouth, and other, you know, so yeah, just trust yourself, trust your gut. Don't let people kind of sway that. If you've got good intentions, it'll come out.
Thank you so much, Serena. It's been an absolute pleasure working with everyone.
And we're getting a lot of thank yous. As mentioned, this information is so timely. Thank you, Trish and Carolyn, for your wonderful presentation. I'll turn it to Trish if you want to end the session.
Yeah, so thank you all for attending. Before we go, I wanted to invite you all to register for the next patient engagement lunchtime learning session on November 4th around budgeting for patient engagement.
Oh, yeah, and pay us too.
Yes. Always pay patient partners.
I love
my
that.
message for this talk. But I'll also share some updates on our budgeting talk to reflect the current virtual situation and COVID, and how to use our downloadable Excel budgeting tool that can be used to develop a budget for any funding applications that include a patient engagement component. Thank you all for attending. Have a wonderful day. Stay safe. And if you want even more information on any of these resources or what we do, you can visit us at www.chimb.ca. Might want to get that one right. All right, everyone. Thanks and take care.
Thanks.